Welcome, and thank you for coming to today's program. This is the webinar series from the Ioneer Foundation called Sight and Sound Bites. This bi-weekly webinar series highlights research at the University of Pittsburgh School of Medicine. Today's topic is retinal dystrophies, introduction, therapies, and ongoing research. I'm Lawton Snyder, CEO of the Ioneer Foundation. The Ioneer Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide through the foundation support research, which is only made possible because of philanthropic supports. So we want to thank everybody who supported us through the foundation. And the kind of work you're going to hear about today is a result of some of that philanthropic support. Some housekeeping rules. We're going to, we've disabled chat. So you won't be able to chat to your friends or any of us, but you can ask questions. And we really encourage you to do that. So through the program, if you have a question, just click on the Q&A button, which should be at the bottom of your screen, type your question, and we will get to all the questions after the program is complete. And we'll make sure to read all of those. We will ask that you refrain from asking personal health questions. I may pass by some of those and we'll get back to you if you do ask any of those that other audience members may not be as interested in. We'll try to answer those when we can, but maybe send us those in an email that you can send to Mr. Craig Smith, who was in your invitation. Please feel free to use the subtitle function for closed captioning. And we'll be adding any newcomers to our mailing list to receive future webinars and information about webinars. So the first person and the only person I'm going to introduce actually to today's program is our distinguished professor and chairman, Dr. Jose Alain-Sahel. Dr. Sahel is the distinguished professor and chairman of the Department of Ophthalmology at the University of Pittsburgh School of Medicine. And he's an exceptional class professor at the Sorbonne University in Paris. And he's the Ioneer Foundation Chair. Dr. Sahel, so good to see you. Thank you to come on and introduce today's program.
Thank you very much, Lonnie. Very, very pleased to be here and to introduce our new speakers. So as you know, we have been working over the past several years on retinal degeneration. It's a large group of conditions that are resulting from genetic defects, gene mutations, and can lead to very severe visual impairment and in some cases to blindness. There's a lot of research that is occurring in that field worldwide, but especially here and also with our collaborators in Paris and other places, trying to understand the course of the disease, trying to characterize the impact on patients in terms of the expression of the disease, how we can image that, how we can document vision loss, but also with a lot of new therapies that are emerging. One of the great news is that the first approved gene therapy worldwide is now in Pittsburgh, and we became a center for this new therapy for one very specific form of gene defect in children, leading to early onset loss of vision. But we are developing many other therapies that are upcoming. Some are already in clinical trials. Others are very close to being in clinical trials. And as you know, already some very early results are very promising. So it's early days, but a lot of hope. But hope has to be based on facts, on data. And some of the data are really based on the genetic basis of the disease, understanding the genetic basis of the disease. I'm very fortunate because I work almost every day with Michelle Alabek, a genetic counselor that was recruited shortly after my coming to Pittsburgh, and is working with us to organize the clinic, to help patients to handle all the gene counseling. And thanks to the partnership with Foundation Fighting Blindness, we are able to provide that to everyone. And also very fortunate to host Boris Rosin. Boris came as the Magwin Fellow to train with us on genetic degeneration, coming from Jerusalem. He's an MD, PhD, trained in engineering, in neuroscience, in ophthalmology, and he's now staying with us. He will be a professor in the department from July on, working on all these conditions. So we asked them to prepare for today an overview of where we are in that field, knowing that this is work in progress, so it won't be as advanced as you may hope, but you will be surprised of the amount of progress that has been made in the past few years, and so many very uplifting and promising avenues that we are exploring now. So without further ado, I'm going to hand over to Michelle, I guess, or to Boris. Boris first. So Boris Rosin is going to take over from me, and I'll stay here to address any question that could come up later on. Thank you.
Thank you so much, Dr. Sahel, and thank you and Lonnie for the opportunity to speak before this audience. And I've been tasked with a very difficult task of talking about all these diseases and summarizing it in a very short time, so I'll get right to it. The functional cells of the retina, the photoreceptors, and they deal with a process called phototransduction, and that is basically taking the light stimulus, the picture that we see, and translating it into a language that the brain understands, and that is a language of electrical potentials. We have two main types of photoreceptors, and they differentiate, when we differentiate them according to the shape of their outer segments, this stick coming out of the nucleus, so to speak. And we have the rods and the cones. And of the cones, we have the three subtypes that give us the sharp vision, color vision that we see every day. And these are the red, green, and blue cones, whereas the rods are more sensitive to light and they function predominantly in darkness. The distribution of these photoreceptors is also different within the retina. The center of the retina, the thing that we use for sharp color vision, is predominated by cones, as we can see here in the upper slides. And as we move out of the center of the retina, rods become more and more predominant. And this is the same concept demonstrated on a histological preparation of a postmortem eye. The actual sensing of the light is done by a superfamily of proteins called the opsins. And these opsins are transmembrane proteins within the retina and within the photoreceptors. And within them, they contain a very special molecule that can be seen here in yellow, and it's called the retinol, which is basically a derivative of vitamin A. When exposed to photons, the retinol changes in its configuration from cis to trans, but these are just names. In essence, it changes its shape, and then change of shape allows it to disengage from the opsin, and that in essence initiates the phototransduction cascade. There are many types of opsins, and different opsins have different sensitivities to different wavelengths of light. So when we analyze that sensitivity within the photoreceptor cells of the human retina, we can see the rods, the night sensing photoreceptors here, around 500 nanometers, and the blue, green, and red cones. And this is the phototransduction mechanism, which is very complex, but the idea is simple. The light hits the rod in this particular case, and then the opsin disengages from the retinol, and that initiates a cascade, which in the end opens a membrane channel or a lot of membrane channels that changes the electrical potential of the cell, and that results in transduction of electrical activity within the retina and then towards the brain through the optic nerve. And also, when looking at this picture, you can also start to appreciate what diversity we have in this group of diseases called the inherited retinal dystrophies, just because there are a lot of things that can go wrong. And essentially, a mutation in any of the participants in this and other processes can, and indeed does, cause an inherited retinal dystrophy. So what happens to that derivative of vitamin A that changed its shape and initiated the entire thing? When interestingly, the photoreceptors do not have the means to change it back and be ready to be activated again. And they need a monolayer of cells immediately beneath them called the retinal pigment epithelium. And there is a very complex array or cycle of proteins which got termed the visual cycle, and that basically recycles the vitamin A. And once again, mutation in every one of these numerous components here can, and indeed does, cause an inherited retinal dystrophy. So once again, an enormous variety. How do we test the function of the retina? Well, the most important test, unfortunately, we cannot go in great length into it, is the Electro Retinogram, where we place a small electrode on an anastasized cornea or in the vicinity of the cornea. and stimulate the retina by specific types of light. And these specific types of light are designed to accentuate the response of certain types of photoreceptors, either the rods or the cones. And there are different conditions under which we can accentuate the response of a certain type of photoreceptors. So let's go over some cases. Case number one. This is a 36-year-old male, usually healthy, and he complains of decreased visual acuity, which is progressive and only partially improved with glasses. He has difficulty going down the stairs and he's stumbling. And as a child, he had difficulty playing ball games, reporting that he was always hit by a ball coming from the side because he couldn't see it. He has severe disability at night, especially when really in dark environments, such as camping. And he has two brothers with a similar problem. On physical examination, his visual acuity is more or less half of what we'd expect for a person his age. He has no problems with his anterior segments. The anterior part of the eye seems fine. And when looking at his retina, we see a very characteristic disease. We see a very characteristic picture of a disease called Retinitis Pigmentosa, and this is also confirmed by genetic testing. So what is Retinitis Pigmentosa? Retinitis Pigmentosa is in essence the leading cause of inherited blindness. Its incidence is about 1 in 5,000 live births, but that it does not include things that are syndromic, meaning patients that have Retinitis Pigmentosa and something else, such as Usher syndrome, in which patients, in addition to the Retinitis Pigmentosa, have a difficulty with hearing. When we include these, we get to up to 1 in every 4,000 live births, and the total incidence of all of this family that we're talking about is about 1 in every 3,000. So this is the vast RP, Retinitis Pigmentosa, is the vast majority of all cases. It's actually a family of diseases. It's not a single disease because many genes can cause the same appearance of the retina, but we treat it or we regard to it as Retinitis Pigmentosa because it looks alike when you see the patient in clinic. And as such, many modes of inheritance can occur, and Michelle is going to discuss that from the genetic counseling side, but it can be autosomal recessive, autosomal dominant, which is usually milder, and X-linked. So basically all modes of transmission can occur. So how does Retinitis Pigmentosa look? This is a normal eye, and we can see the optic nerve, we can see the blood vessels emanating from it, and the central vision, the macula, which as we said is predominated by cones, and the peripheral retina, completely normal retina. This is the same picture using a different technique where we use a particular wavelength of light which accentuates certain pigments within the retina. Once again, completely normal. We can see the optic nerve now in black, blood vessels, and this a little bit of area of a small kind of like hypofluorescence or low fluorescence is completely normal. And this is the fovea, the very center of our vision. What happens in patients with advanced retinitis pigmentosa? There are 3 cardinal findings. One is optic nerve, the optic nerve that appears to be very pale. The blood vessels appear to be restricted or attenuated, they're thinner, and there is deposit of pigment in a certain pattern called bone speaker-like pigmentation. When looking at the same fundus autofluorescence technique that we mentioned before, we see a lot of black patches, which are basically indicative of atrophy, and there is no doubt that this is indeed a very sick retina. When looking at patients from the same family with the same mutation and looking at their optical coherence tomography and imaging technique over a course of time, we can see here that the retina is actually becoming more and more atrophied as the patients age. So here at 12 years old, we have a very nice striped structure, and most of the layers of the retina are preserved. But as we move along with age, we can see A, that we lose the stripes, and B, that the retina becomes thinner, it becomes atrophy. And this is indeed the course of the disease. As for electroretinography, so on the right, we can see the responses of a normal retina. And this is as to compare with that patient, we can see that actually he has no recorded response. It doesn't mean that the retina is necessarily not functioning at all. It just means that there are not enough cells to invoke a recordable response. Another very useful test is visual field, where the patient is asked to fixate at a certain point in space, and then different stimuli are presented at different points in space, and the patient needs to press a button when he sees such stimulus, and we receive a mapping of his visual field. And this is another type of this device. And we can see that as the patient's age, the visual field, which is larger here, becomes more and more constricted until a very small island of vision, a phenomenon we call tubular vision, is all that remains. Case number 2, a 27-year-old male college student. At the age of 9 months, the parents noticed that he's squinting in the sun. He has trouble with bright lights, but really he has trouble with all lights, even in the supermarket. And he was diagnosed with a retinal degeneration without a real diagnosis. His real complaints are photophobia, decreased visual acuity, poor color vision, and nystagmus, which are rhythmic, uncontrolled eye movements since childhood. Medical history is completely unremarkable. His physical examination is basically normal aside from his visual acuity, which is reduced. And when we're looking on the OCT, it's not as striking as the OCT that we saw before. However, there is a hint here of something going on under the center of his vision. Genetic testing revealed a mutation in a gene called CNGA3, confirming the diagnosis of a very rare disease called achromatopsia. Achromatopsia is a very rare condition. It occurs in 1 in every 30 to 40,000 live births, and it is characterized by severely reduced visual acuity, sensitivity to light, nystagmus, the uncontrolled movement, and markedly impaired color vision. If we can look here at the flag, you can see this is how the flag is seen by a normally sighted person, and this is complete lack of any color perception. In achromatopsia, to that, we need to add also blurry vision. And the reason for it is that their cone photoreceptors are completely malfunctioning. So this is the response, bottom response here is the response of the cone photoreceptors, the normal photoreceptors, and we can see this ragged response here, which is almost completely absent. And this is in essence the problem in achromatopsia. It's the patients do not see color just because their cones, which are there, are not responsive. As we said, it's a very rare condition, but there are 2 places in which this condition is more prevalent. One is my native Israel, where the much higher incidence is due to the fact that 2 religious populations, the Ashkenazi Hasidic Jewish population and the Muslim Arab population, have the tendency of intermarriage, consanguinity, and that always accentuates these diseases. And the other one is the Pingalap Island, which is part of Micronesia in the Pacific. And there, because every marriage by definition is consanguineous, it has reached the amazing and staggering incidence of 10%. And this island is very, very interesting. If you're interested in books by Oliver Sacks, there is a book called The Island of the Colorblind that talks about this particular island. So this is an actual picture of this island. And it's very ironic and in a bad way, because a person that has achromatopsia has a lot of trouble on this island. A, they're very bothered by the bright sunlight, and B, they see everything very, very blurry and more or less black and white. So let's now talk about therapies and models for hereditary retinal dystrophies. And the first thing is gene therapy. And the concept, at least conceptually, is simple. You take a virus and you empty it out of its genetic component, and you load it up with a gene copy of a gene that you would like a target tissue to express, and you infect it. So in a retina, let's say we have a patient with achromatopsia, we know the mutation, we load it with a copy of CNGA3, and we can infect the retina with it. However, this is not necessarily the only thing that we can do with gene therapy. Cones and rods are interconnected with many things. We mentioned the visual cycle, but they also secrete certain factors that produce the health of each other. And we will talk about such factors. And you can potentially make cells in the retina express such factors, promoting the health of photoreceptors. You can also inject something that will express regulatory proteins, reducing or increasing the expression of certain genes. And you can induce photosensitivity, infecting cells that previously were not reactive to light with opsins, with these proteins that we were talking about that are reactive to light, and in essence, creating bypasses to the retina and creating artificial photoreceptors. The retina is the ideal tissue for gene therapy, and this is why it has pioneered the research in gene therapy. It's a small confined tissue. It is readily accessible for injection, And as we saw before, there are many clinical and functional tests that we can use in order to follow up the progression. So up until very recently, all the research that we had in the field of hereditary retinal dystrophy was focused on diseases that had naturally occurring animal models for them. And Dr. Sahel has mentioned Luxturna, which is the drug used to treat Leber's congenital amaurosis. And it all originated from these very cute dogs called Briere dogs. And they have actually a lineage of these dogs expressing the very same mutation causing the disease and a very similar phenotype or appearance to the patient. And this is the gene therapy trial on the dogs that was published in 2001. And you can see here on the responses that the normal dogs have good responses on their electroretinography, and the pre-treated dog have almost none, and dogs that were treated have much better responses, meaning functional retinas. Another miraculous discovery was that, once again from Israel, of a herd of sheep in the north part of the country that expressed the same mutation that we talked about that causes achromatopsia. And this is Professor Eyal Banin, my friend and mentor from back home, who spearheaded this research. Sheep are usually very, very social animals. So if a sheep stands apart from the flock, they want to join the flock. But these sheep do not see during the day because they only see with their rods, and the rods are saturated during the day. During the night, they can see. So genetic testing was performed, mutation identified, and the sheep were treating by injecting a viral vector carrying the correct protein under their retinas. And this is an example of what happens with that. So we can see the sheep before treatment. During daytime, it's trying to find its friends. Over here, it can hear them, but it cannot navigate this little maze to get to them, so it's quite confused. It will have no trouble doing so during the night, but this is after treatment, same conditions during daytime, and you can see the sheep very nicely navigating this little maze and happily getting back to the herd. So let's talk about what happens when the photo is when we don't know the exact mutation that causes the disease. We talked about these trophic factors, or factors that promote the health of photoreceptors. And one such factor, the blood-derived conveyability factor, was described by the group of Dr. Sahel back in France. And this factor actually, when you have cones in animal models of RP exposed to it, not only do they promote the viability of the cones, but actually you can see the elongation of the outer segments. So they actually basically also improve the function of the cones. So you can envision gene therapy directed towards these targets when you don't really have a mutation that you're aware of that causes that particular disease. And this is very important because while we're aware of 75% more or less of the genes causing hereditary retinal dystrophies, 25% still remain unsolved. What happens if the photoreceptors are completely gone? Well, if the photoreceptors are completely gone, what you can imagine doing is infecting the remaining cells with basically opsins, with proteins responsive to light. So the other cells of the retina can, in essence, become photoreceptors. And this is, again, a study spearheaded by Dr. Sahel, where opsins from algae were taken and used to infect the retina. And in a very recent article in Nature Medicine, a patient that was not seeing prior to treatment was treated as such, and there are special goggles that need to basically connect it to scanning sensors, and they use a special wavelength of light in order to activate these opsins, but the patient was able to identify objects laid in front of him, and there was also recorded activity from his cortex. Stem cells. So stem cells are actually the ultimate replacement therapy. So you have a cell that has degeneration of the photoreceptors, and you basically would like to take and replace it in its entirety. And you can think not only of photoreceptors, but other cells such as Retinitis Pigmentosa. And stem cell therapy has a little bit of apprehension when approaching it, just because people believe that embryos are needed in order to derive these cells, but this is completely not true these days for two main reasons. Human embryonic stem cells are mainly derived in the lab. They're basically were harvested many, many years ago. And right now you have, these cells have an unlimited amount of division potential in them. So you can basically harvest them from the lab in an unlimited amount. And we now also have the ability to take cells from a specific patient and push them back, push their differentiation back towards being stem cells, and then push them towards being either photoreceptors or RPE. Once again, preliminary data for another disease, age-related macular degeneration, from the group in Israel, from Professor Bonin, where they injected such stem cells pushed towards RPE phenotype. And basically what they believe is that the creation of this new RPE-like structures next to the areas of atrophy limited the extent of the atrophy. And this is now going to phase 2 trial. And once again, Michelle will discuss the phases, and we can see again here the stippling of pigment next to the area of atrophy, representative of RPE cells. Another very exciting field, which gets a lot of attention these days and becomes more and more important, is that of retinal organoids. And it was pioneered by a Japanese investigator named Sasai, who noted that when you put stem cells in basically loosely connected environments or loosely connected plates of growth media, they tend to flock together, and eventually they create neuroepithelium. And he asked a very simple but ingenious question: well, what will happen if I take my culture and make it 3D, a three-dimensional culture? And surely enough, they form what we call retinal organoids, or basically eye cups or eye-like structures that manifest a lot of the eye tissues, including the retina. And the applications are staggering. You can basically test gene and cell therapy on it, but you can also envision harvesting these retinas formed artificially and basically implanting them and using them on a chip in order to fix things. And this is a very, very hot field, widely discussed these days. Retinal prostheses. So there are a lot of types of retinal prostheses. Some of them are biological, some of them are artificial. We will discuss one such retinal prosthesis invented by this gentleman here, Professor Daniel Palanker of Stanford, who, to my greatest honor, is also an alumni of the same department that I come from Hadassah University Hospital in Jerusalem. And he created this miniature array of photovoltaic cells that are implanted under the retina. So essentially, you completely bypass the retina. And this is Dr. Sahel, who was also very, very involved in development of this particular array. And this picture is actually a little bit misleading. You would think that this white thing here, white circle, is the array. No, it's actually this very small speck in the middle of this container. And this is Dr. Yossi Mortel, one of our retina specialists, with yours truly assisting, actually performing the implantation. Dr. Mortel created a flap of the retina and pushed the array under it, flattening it with heavy fluid, and that basically kind of like sticks it in there. The heavy fluid is removed, and the array is under the retina, transmitting directly to the brain, bypassing the retina altogether. Last thing that I'm going to mention is CRISPR. And CRISPR is basically piggyback riding on a mechanism employed by bacteria to correct gene defects that were caused by viral infections. And we have an amazing molecular biologist in our department, Dr. Leah Byrne, with whom I have the honor of collaborating on my own projects. And she employs these in many, many ways. And that can be correction of genetic defects. So obviously, if you have a genetic defect and you have an editing mechanism, this is what you could do. But you can also create new models with it, because if you take a stem cells that you are using to create a new organoid, you can induce a mutation which you're interested in basically researching, and then create an organoid expressing that mutation. And you can also create new animal models. And this is perhaps the greatest revolution of CRISPR, because as you noted, up until now, we were very much reliant on existing models. However, CRISPR gives us the modes or the means to create any model that we would like. And so this is more or less the vision of Dr. Sahel for the New Vision Institute. And this is why I so much wanted to be a part of it, to come together and to have basic science on one hand and clinical science on the other hand, coming together and sharing experiences and coming up with treatments that will benefit our patients. Thank you so much for your attention. And I will now yield the stage to Michelle, who will talk about clinical trials.
Hi, thank you, Dr. Rosin, and thank you, Lonnie and Dr. Sahel, for asking us to give this presentation today. So as you can imagine from what Dr. Rosin shared, there really are a ton of advances and new developments that are going on in this field. And at this point, wanted to take a step back and make sure that we are also giving the attendants a background on kind of what clinical trials are and some terminology that you might hear, and kind of how those come to fruition and how we bring those to patients. So I'm going to start with an overview, just go over some general terminology. So you may hear something called a natural history study. This is really kind of a study that collects data in a very standardized way in order to understand and document the normal progression of a disease. This can be very helpful in laying the groundwork for future clinical trials. Clinical trials are referring to when a human subject is given some type of intervention or treatment with the goal of evaluating the effects of that treatment. When you hear the term protocol, that's referring to the specific design of a study that's planned with patient safeguards in place, as well as a very specific research question and how they aim to answer or address that research question. Informed consent is referring to a document that explains to the potential subject or the potential participant, all of the different risks, potential benefits, and things that they may want to consider before deciding whether or not to participate. A couple other terms that I just want to go over in a little bit more detail. So you heard Dr. Rosin mention a little bit kind of the phase of some trials. So when we conduct clinical trials, really, those are done kind of in various phases and they progress from one to the next. Usually each successive phase has their own specific protocol. It typically can involve larger patient population or cohort sizes as we move forward. So this diagram, I will say, the participant numbers that are listed here are not necessarily kind of written in stone. This is not specific to retinal dystrophies, and that's not a scripted number. But I liked that this diagram kind of walks you through the preclinical work that takes place first. And that really is where they're testing a drug either in a cell model or an animal model, really before it's approved to start use in humans. Then the drug would move into what's called a phase 1 trial, where really the primary purpose is to test the safety, and is often done in a small number of patients and potentially is done in patients with much further advanced stages of disease. Moving into phase 2 trials, start looking more at the effectiveness, still monitoring the safety, but also, what is the effectiveness or is there an effect of this drug? And that is a larger number of patients. Then moving on to the phase 3 trials, where you're again looking still at the safety and the effectiveness, but really looking in more detail at any side effects that are happening in a larger population of patients, and comparing that to a standard of care if there is one that exists. Once phase 3 trials are finalized, all the data is analyzed, and the FDA would then review to decide if it's a drug that meets the requirements in order to become an FDA approved therapy that is available for clinical use. And then after that, if a drug is approved, there's additional studies to kind of monitor the ongoing safety, effectiveness, and to optimize the use of that therapy. Another term that you'll hear in dealing with clinical trials is inclusion criteria. Inclusion criteria refers to all of the factors or variables that a patient or a participant must meet in order to be considered eligible. So in retinal dystrophy trials, a lot of the inclusion criteria are commonly things like age, diagnosis, a specific genetic test result may be required. Visual acuity might have to be within a very specific range. If it's better or if it's worse than that range, the patient would not meet that checkbox. And there may be specific ocular tests. So you might have to have a visual field with a very specific result in order to meet that checkbox, that inclusion criteria. So these, again, are going to be very study specific. Each protocol would have their own inclusion criteria, but these are some of the common topics that you'll see in retinal dystrophy trials. Kind of the flip side of that are the exclusion criteria. And so this is referring to individual factors that if a participant meets them, they would not be eligible for the trial. So even if someone meets all of the inclusion criteria for a trial, if they meet any of the exclusion criteria, they would not be considered eligible. And there are a lot of different factors. And again, these are very study specific. Often the exclusion criteria may be longer or more comprehensive than the inclusion criteria, but things like different ocular diseases. So maybe having a history of cataracts or presence of cataracts currently, if you're pregnant or breastfeeding, if you have some other systemic disease, maybe cardiac history could potentially be an exclusion criteria. Other things that often can be seen in exclusion criteria are things like prior treatment with other investigational drugs, or if you are actively in a clinical trial right now. And so that's something to think about as well. I just briefly wanted to mention, we don't have the time to go into kind of all the clinical impacts of genetic testing, but it does become a very important topic as more and more therapies are developed for these genetic diseases. The genetic test result can often play an important role in the inclusion or the exclusion criteria for a study. And so Hannah Skanga, our lead genetic counselor here, and myself last year had the opportunity to do a webinar through the foundation, kind of going into more detail about genetic testing. So I'd encourage you, if you want more information on that, to refer to that webinar. But really what I wanted to point out is there are a lot of different clinical impacts that genetic testing can have if we can identify the cause for a patient's condition. But really what we're talking about today is this treatment option potential, right? And the more trials that are available, the more therapies that are moving and progressing, this is becoming more and more relevant. Genetic testing is really having more of an impact on deciding and making decisions about options that may be available to patients for new treatments. So these next two slides are a bit busy, but I put them in here more of just as a point. So these next two slides come from the Foundation Fighting Blindness website. They're current as of April 2022, and they highlight all of the active trials that are currently ongoing for retinal dystrophies. And so I broke it down into two really so I could just fit it all in. But the first is talking about gene transfer therapies. So you can see there are many gene transfer therapies that are currently in clinical trials. Most of them, if not all of them, are in phase 1 or phase 2 at this point. And then moving into some of the other types of therapies that Dr. Rosin nicely outlined, you can see different types of therapies as well for retinal dystrophies. And these are anywhere from phase 1 to phase 3. So there's a lot that's going on right now. There are a lot of trials that are out there. And I think, when we see patients in clinic, I think one of the things that, I feel is an important part of our role and that patients are looking to us for is really kind of how do we help assess if a trial is right for an individual. And so, things that I would always encourage a patient and a physician to talk about is really to have a good understanding of the inclusion and exclusion criteria, like we discussed. What phase is the study in currently? What trial phase is it in? Is it phase 1? Are you comfortable with a phase 1 trial? Would you rather wait until maybe it gets to a phase 2 or a phase 3 trial? Or would you rather, wait until, hopefully it would become an FDA approved therapy? Two other things I just want to go into a little bit more detail that I think can help to assess if a trial may be relevant or not. One is just kind of thinking about the timing of intervention. And so Dr. Rosin again touched on this very nicely in his outline of the different therapies. But with these conditions that are progressive, there may be certain therapies that are more appropriate at an early stage of disease compared to other therapies that may be less appropriate at that point, but may be more appropriate in very late stage or advanced stages of disease. So as an example, in early stages of disease where there's still relatively good normal vision, gene therapy may be a more viable or appropriate option at that point. And on the flip side, in very end stage of disease, gene therapy may not be a good option. And things like cell therapy or retinal prosthesis may be a more appropriate choice. And so really understanding what type of intervention, what type of therapy is being provided in that trial, and then kind of comparing that and cross-referencing that to where are you at in the stage of your disease progression at this point. And the last, but certainly not least, is kind of the overwhelming responsibility to kind of weigh all the information, right? What are the pros of participation? What are the cons? And what are all of the other variables that may impact making that decision? So I've listed here, some of the things that I think are important to consider. What are the long-term benefits? Who are the providers that are involved? Are there risks, short-term, long-term? Where does this trial take place? How long are you in the trial? How frequently do you have to come for visits? But certainly there's a host of questions that can be asked and really should be asked, a lot of which are outlined in the individual informed consent for each specific trial. But if you're interested in more detailed list, there is a nice list. I included the link here through the National Institute of Health. So I wanted to put on here, a question that I get often from patients is, there's a lot of therapy going on, a lot of trials going on, but why does it take so long? And so I pulled together, a timeline using Luxturna as an example, really outlining kind of when did it start and how long did it take. And if you look at the timeline here, it's about 20 years was the duration that it took from when they first announced that they identified the natural animal model in the Briard dog in 1998, progressing through trialing it in the dog and then other preclinical studies, eventually moving into the phase 1 trial, the phase 3 trial, and then in 2017 was finally approved by the FDA for use in the US. So it is a lengthy process, certainly in this case, and again, this is just one example, but in this case, they had the luxury, I'll call it, of having a natural animal model that existed. But as Dr. Rosin had discussed, if there isn't an animal model for a particular gene of interest that someone's trying to develop a therapy for, you have to kind of add some time onto the beginning of this timeline in order to develop that piece of it and be able to move forward. So everyone, including us, including providers and patients alike, would prefer that this timeline is shorter, but also we don't want to rush things in a way that we jeopardize the safety for patients. And so really it's done with a lot of intention and responsibility. But there are some efforts that are going on to try and kind of streamline and expedite some of the progress that's made in this area. And so this consortium was started in 2013 and then met again in 2018. It was an international group of clinicians and scientists and really individuals that kind of span the different interests and perspectives that manage patients with retinal dystrophies. And the purpose was really to identify, what needed to be done next, what were the next key steps in order to keep this advancement of treatments moving forward, really with the goal of coming up with recommendations and kind of key priorities that should drive the field moving forward and stimulate discussions, not just among clinicians, but also among other stakeholders like pharmaceutical companies and regulatory bodies. Another organization that's working on this kind of collaboration is the Foundation Fighting Blindness. And so they have something called the Foundation Fighting Blindness Consortium. There's currently last that was announced, 40 participating centers across the United States and internationally as well, who really work to conduct clinical trials in a collaborative way in order to accelerate the treatment. And so they currently have several trials open, several others that are moving, anticipated to start later this year. And so just wanted to kind of wrap that section up with some tips. If you're a patient that's interested in a clinical trial, or if you're a physician or a provider who has a patient interested in a clinical trial, a couple items to consider. I think it's important to attend routine clinical appointments, regardless of if you're interested in a trial or not. But as a point I wanted to highlight, if you are interested in trials, because we rely on the data that we have in order to identify patients that may be eligible. And so having current data on patients can really help us to bring the most current information to them. It can be helpful to gather as much information as you can about your diagnosis, stay up to date on advances in the field. The more that you know now, the less you'll have to learn when you're approached about a potential opportunity. Don't feel like you have to jump at the first opportunity that's available. Participation in one trial potentially could preclude you from participation in a future trial. So you really want to make sure that you're making an informed decision that you do want to participate. If you go through the steps and find out that you're not eligible, it doesn't mean that you won't be eligible for something in the future. So always remain hopeful. So a couple resources here for staying up to date. Obviously, the Ioneer Foundation with their webinars and their newsletters is a great resource. Clinicaltrials.gov is National Institute of Health's website, and they list all of the current trials that are existing. You can search by different filters or terms or genes or whatever you want to look for. As I mentioned previously, the Foundation Fighting Blindness, in addition to their consortium, they also offer, they do a lot of fundraising to support a lot of these new novel therapies. They also do a lot of patient education and outreach as well. And lastly, us here at the Eye Center. So I wanted to just give you a little bit of background to wrap us up about kind of who our team is and how we try to bring these clinical therapies to patients in the most appropriate way. So we have our retinal dystrophy team. We cover clinical as well as research and educational and outreach opportunities. I've included pictures of some of our main team members here, Dr. Sahel and Dr. Rosin, who see our patients in retinal dystrophy clinic, where I'm the coordinator, Dr. Martel and Dr. Chablani, who are the physicians who are certified for our Luxturna therapy, and Dr. Nishal, who helps to manage the coordination of care for patients with retinal dystrophy on the pediatric side. We have several research coordinators and support people in that department as well. And then, we have other services that we offer. We have a team of 3 genetic counselors that I feel very lucky to be a part of, helping patients kind of navigate the genetic testing process once that referral is made. We have a patient navigator who helps to identify any barriers to healthcare that our patients may be experiencing, like health insurance or transportation. We have low vision optometrists, Dr. Smith and Dr. Isaacson, who help to kind of evaluate the visual function of patients who are having progressive vision loss, and determining goals and different support resources that may be helpful to them to kind of improve their visual function. And they work very closely with a team of occupational therapists to kind of execute those recommendations and help patients train. So the last thing I want to wrap up with is, kind of what's our process look like when we start a new trial here at UPMC, and how we try to make sure that we're bringing that to the patients that we think it's the most appropriate for. So once we get a new protocol, we kind of review all the details, we review the inclusion and exclusion criteria, and then we review the list of patients that we have and the most recent data that we have for those patients. Kind of filter that list down to patients that look like, based on the last data we have, would be good eligible candidates for this trial if they would be interested. Then we would reach out and contact the patients to make them aware of this potential opportunity, give them some basic information about the trial. We can share the consent form so that patients can take some time to review that themselves, as well as with their family to discuss. And then we always encourage a conversation appointment with the physician to really answer any questions they have, learn more about the study. And then ultimately, if interested in proceeding, would move towards a screening visit, where that's kind of the first step in a clinical trial to make sure that you truly do meet all of the inclusion and exclusion criteria at the time of enrollment. Certainly, patients can kind of opt out of this at any point. Just because we make you aware of a potential trial that you might be eligible for does not mean that you have to participate. You can think that you're interested, and then you have the discussion with the physician and decide that it's not for you. We don't mind how it ends. We just want you to have the information so that you can make an informed decision. So that's the end of my content that I wanted to share. So I think we're going to open it up for questions. Thank you all so much.
Yes, we are going to open up the questions, and I'll start by just thanking our presenters, and Dr. Sahel was a very informative presentation. And I can, from one of the questions I already answered earlier, just for everybody to know, this is recorded. So we will have an opportunity to post this. It's going to be posted on our website in really just a few days. So if anybody would like to see it again or send it to friends, remember that that's available. We have a lot of questions already, but this is the time if you want to submit some additional questions, go to the Q&A button below and type in your question at the bottom. So I'm going to start here. And so the first question, even though, I don't know how much this pertains to everybody, but still, is there any current information about rare mutation genes TUBB? Is that something that we are studying or have information on?
Dr. Sahel, do you know if there's anyone currently researching that? I'm guessing that's the TUB4B gene.
Yeah.
Yeah, no, I think there is a lot of work on understanding the effect of a gene defect, but I don't think there is currently a clinical trial planned in the short term. But this is a very interesting gene that I identified many years ago and still analyzing. Actually, as late as last week, I saw a paper on understanding better the biology of it, but I don't think this is yet leading into a clinical study.
Wonderful. And as Michelle mentioned earlier, if anybody looking at when clinical trials are becoming available, those resources that she gave really are, looking at the websites, looking at the information, getting signed on to receive these webinars and information. We're going to try to keep you as informed as we possibly can.
Yeah, just a word of caution on the clinicaltrial.gov website. Any study is listed, but some of these studies are not really full clinical trials. For example, some of the clinics that provide the stem cells injection in Florida, actually, this is not a trial, but some of them are listed as a clinical trial. So one of the clues to determine whether this is a valid trial, anytime you are asked to pay for a study, it's not a trial. So it's a very easy clue. Anytime someone is asking you to pay for something, it means that this is not a trial.
Very good advice. Thank you, Dr. Sahel. So at what point should I switch from going to an optical shop to seeing a specialized program if I'm experiencing these types of symptoms? Every situation is different, but are there any guidelines?
Yeah, so we do not really have any guidelines, but I would say, basically, if you feel that the regular optical shop is not able to bring you up to the point that you're satisfied with your daily function, that would be perhaps the time to be evaluated by a low vision specialist. And we're very lucky to have Dr. Smith on our team, who's amazing in doing that. And that's a very big aid to people that have inherited retinal disease.
So how many centers across the country have these types of advanced retina RP programs, including genetic counseling?
Yeah, so I think it's a little bit of a moving target. I don't have a specific number to put on. A couple, there are 40 organizations that are in the Foundation Fighting Blindness Consortium. That does include international sites as well. So it's certainly less than that in the United States. But I think that there are quite a few programs in the U.S. But Dr. Sahel, do you have a gauge of number? You're muted.
Sorry, it's between 15 and 25 centers. Actually, if you go to the website of Foundation Fighting Blindness, they are providing a list of physicians or centers in each state of the country. We are part of the consortium. We are part, actually, the Money Channel we have been part of that. So all of this, we are part of that. It's a great community that was built over the years. You have to remember that many people started that at the time there was no therapy. Nobody knew anything about the gene defects. I can remember these days. So these are very committed people that have been focusing on that over many years. But currently, with all the therapies emerging, there are more centers, but not all of them has the same level of expertise. So I would say between 15 and 25, but not more than that.
Thank you. So what are your thoughts on having in-depth eye care if a sibling, or I guess I'd say any relative, right, parents or any blood relative, that has a retinal dystrophy, but you yourself aren't showing symptoms yet. Should you be seeing somebody once you know that you have a family member that's experienced a inherited retinal disease?
I think I'll take this one, Lonnie. So I think that it's always a good idea to have a good retinal exam by a retinal specialist for any patient that has history of a hereditary eye disease in the family. However, if you're talking about a very thorough workup of the kind that we do in our center and other centers, I think that this needs to be done if there is real concern as for the possibility of an inherited retinal disease. If you're experiencing symptoms on one hand, or if a retinal exam revealed findings that are concerning for the existence of such a condition, then yes, we should see such a patient and do the thorough workup that we do usually.
And I think also if there has been an identified genetic cause within the family, we can help to offer genetic testing or counseling for that unaffected or presumably unaffected individual at that point to kind of understand what their risks are and decide if they may want to move forward with genetic testing, or potentially they're actually not at risk based on what the inheritance pattern is in the family. And so I think gathering information on the affected relative and then reaching out to a center like ours, or somewhere local that can help answer your questions. But certainly, that's one of the things that we try to do is help the relatives understand their risks as well.
I'll follow up with a question to that. Would that type of service be covered, paid for by insurance, if you just are exploring whether or not you have those genes and indeed have the risk of that?
Asking if the genetic testing is covered. Mm-hmm. So it would depend by insurance probably. And I think, it's our job as the genetic counselor who's helping to facilitate that testing. If a patient's interested in moving forward, to figure out what the costs associated with that may be. If we can go through insurance, we would help to submit a prior authorization, see if there would be a cost associated with it. We can really use some arguments of how this would impact clinical management if we were to identify that someone had this type of condition or this predisposition to develop this type of condition. And so it's possible that it could be covered through insurance, but it's very different on a case-by-case basis. There are labs that we use, though, that offer very accessible patient financial assistance programs and can get the cost of testing down usually to under $100 for unaffected relatives. So, that makes it's not $0, but it makes it a little bit more affordable or less intimidating to think about the potential cost. But again, that's if we know the specific genetic result that's been identified in the affected family member. That's really critical.
Wonderful. That's actually very wonderful to know. How do I become part of a study at UPMC Eye?
I'll start. So I think obviously the patients that are established with us and we know who they are and we know their diagnosis and we've done some of the testing, as new trials become available, it's easier for us to know to approach those individuals and make them aware of the opportunity. So I think if you are local to Pittsburgh, or if you're interested in traveling to Pittsburgh, really having either Dr. Sahel or Dr. Rosin coming through our retinal dystrophy clinic and having one of them do a formal evaluation and workup so that we can really understand kind of where you're at in your stage of disease. If there are certain tests that you haven't had done that we know would be helpful, like genetic testing, we can help to get some of that stuff in motion. So that as new trials become available, you're kind of already in our system. We know who you are, and then we would know, to reach out to you.
Well, this is a personal question for you, Michelle. How did you decide you wanted to be a genetic specialist? This is an interesting field to study.
It is. I think that's the answer. The answer is in the question. It's a very interesting field of study. I think, I was interested in healthcare, but also very interested in kind of the patient experience and how we make how we engage patients in that as well, and the psychosocial aspects that come along with a new diagnosis and kind of navigating and incorporating that into your life. And so, I kind of fell into it a little bit, but certainly almost daily feel like I fell exactly where I should be.
I agree. So it seems that there are many new gene therapies being brought to patients. Do you think that we'll see many more over the next few years?
There is zero doubt that we will. And certainly every disease that is of the types that we've discussed with regards to gene therapy, such as achromatopsia, kind of like single gene, single protein kind of disease, is a candidate these days for gene therapy. And I'm certain that with the next decade, we're going to see many more diseases and genes come under this umbrella of approved therapy for these conditions.
So if someone's losing color vision in one eye, what type of specialist should they see?
They should definitely see a retinal specialist. Okay, so as we discussed, the cone photoreceptors are the cells that are responsible for perception of color, and loss of color vision in one eye is usually not characteristic of a genetic condition where all the cells of the body are affected equally. However, there could be other things, acquired insults to the retina, that could cause such a condition. And this is certainly something which is worth evaluating.
And to be optic nerve also used. So it should be, it could be retina or neuro-ophthalmology. Yeah.
So last question here, and just at the end of the hour. How do we contact Ioneer to get started getting information on the clinical trial? So I can tell you the Ioneer Foundation, of course, you can always pull up our website, www.ioneer.org. You can sign up to receive our newsletter. You can sign up to get information about things like this, like our webinars. But in addition to that, Michelle, if you want to fill in.
Yeah, so I would say on the UPMC Eye Center's webpage, there's a section under services that is primarily focused on the retinal dystrophy clinic. So you can, under services, navigate to retinal dystrophy clinic. There's information in there, some of which we went over today, but the first thing on that page is our retinal dystrophy email address, as well as our retinal dystrophy phone number, which is managed by myself, as well as one of our support staff, Morgan, who's been a huge help at kind of keeping up with all the inquiries that we're getting. So that would be the best first line of contact. Either call us at that phone number or send us an email, and then we can talk about next steps, based on the information that you share.
Okay, once again, thank you to all of our presenters, and this has really been a very informative and very comprehensive program that I think, again, people will want to keep coming back to. As I said, this will be posted on our website in just a few days, and please feel free to go to it, share it with friends, and again, please feel free to send us any questions you may have. Thank you all. Have a wonderful day. And again, panelists, thank you.
Thank you all
Thank
so
you.
much.
Okay.